Hello, everyone. My name is Patrick Conn from Baptist Best Health, and I want to welcome you to our Best Cares presentation on migraines led by Dr. Shay Johnson. Before we begin, just be aware that this presentation is being recorded and will be shared with you via email. Also, it will be posted on our Best Health SharePoint site. So without further ado, I will now hand it over to Dr. Johnson to tell you a little bit more about herself and then to start the presentation. So I'm going to hand it over to you, Dr. Johnson.
Thanks so much, Patrick. Like he said, my name is Shay Johnson. I'm the current PGY1 community-based resident at Mississippi Baptist Medical Center in Jackson. A little bit about me before we get started. I graduated from the University of Mississippi School of Pharmacy in 2023 with my PharmD, Hottie Toddy, and I currently live in Jackson with my husband and two dogs. Now on to our presentation, migraines, when it's more than just a headache. I will be taking questions at the end of this presentation. After this presentation, you should be able to identify signs and symptoms of a migraine, identify common non-pharmacological therapy, know the difference between acute, preventative treatment, be able to identify over-the-counter medication options for a migraine, and recognize common prescription migraine medications. So to start off with, we're going to go over exactly what is a migraine. A migraine is a common neurological disease that is associated with nausea and/or light and sound sensitivity. These headaches are often unilateral, meaning that they affect only one side of the head. When a migraine occurs, the pain can occur over the course of several hours to days, depending on the severity. There are no biological markers for determining if somebody is prone to migraines, and this can make it difficult to diagnose migraines because many conditions can also present with the same symptoms of a migraine, such as stroke or epilepsy. A term that gets used a lot in relations to migraines is an aura, but what exactly is an aura? It's a set of sensory disturbances that affect about 1/3 of patients suffering from migraines. Generally, an aura will happen shortly before a migraine attack and consist of sparks or bright dots in a patient's vision. And auras are sometimes thought of as a warning system for a migraine attack. Migraines affect 12 to 15% of the general population, with females being more commonly affected than males. Prevalence of a migraine attack generally peak between the ages of 18 and 39 years old, and migraines are a major cause of disability with impaired functional ability at work, school, at home, and in social situations. Migraines are also a major cause of financial burden. In 2018, patients in the United States spent an estimated $17 billion annually due to direct cost of migraines. This cost is related to loss of productivity during work hours and reduced quality of life because of migraines. Migraines are also one of the fourth most common reasons patients will go to the emergency room to seek treatment. Diagnosis of a migraine is based on a patient's history and physical exam and diagnostic criteria, which we will discuss in a little bit. Some clinical features that are most predictive of a migraine include nausea, photophobia, which is sensitivity to light, phonophobia, which is fear of sounds, and being exacerbated by physical activity. The International Classification of Headache Disorders, 3rd edition, or ICHD-3 criteria for migraines is a diagnostic tool that helps determine if a patient is having a migraine or chronic migraines. This tool takes into account the frequency of monthly migraine days, so MMDs, and monthly headache days, MHDs. Providers can utilize this tool to help determine if migraines are more frequent or episodic in nature. So if a patient is having migraines periodically or more chronic every other day, multiple times a week. Certain factors can trigger a migraine or exacerbate symptoms, and these factors are commonly called migraine triggers. Making sure that patients are aware of their migraine triggers is an easy way to help um, prevent worsening a migraine attack. Some of the common migraine triggers are listed here, such as emotional stress, weather, bright lights, hormones, disturbances, smoke, not eating, odors, and foods. Not every patient with migraines will have the same triggers, so it is important to be aware of possible triggers for different patients as well. So, as an example, one of my desk mates that I share an office with, she does suffer from migraines, and one of her triggers is the smell lavender. So I have to be very careful. If I were to wear lavender or have lotion that smelled like that, it may trigger a migraine for her. Some non-pharmacological therapies for migraine treatment include avoiding migraine triggers, just like we discussed. There's also techniques such as deep breathing exercises or muscle relaxation. Some patients do find that cold compresses can help soothe the pain of a migraine, and a headache diary can also be utilized to track how many days a patient has had a headache. This is also very useful way to find out if there's maybe an unknown trigger through documentation of the patient's migraine attacks. Generally, with migraine therapies, there are acute and preventative treatment options, which have different goals for the patient. With acute treatment, meaning treatment at the onset of a migraine, the goal is to provide rapid and consistent freedom from pain associated symptoms while having a minimal need for repeat dosing of medication and restoring ability to function. These are medications that will be used to treat at the first sign of pain. Suboptimal acute treatment is associated with higher migraine related disability and risk of disease progression. All patients with a confirmed diagnosis of a migraine should be offered a trial of acute pharmacologic and non-pharmacologic treatment. Preventative treatment is treatment that will help try and prevent a migraine attack from happening, and these medications are taken continuously. The goals of preventative treatment are to reduce attack frequency and improve function and reduce disability for the patient. Not every patient suffering from migraines will receive preventative treatment, as it is generally reserved for patients that have a large number of headache days in a month with a large degree of disability. Preventative treatments can also be utilized in patients with poorly controlled attacks and those at risk of medication overuse. When treating a migraine, patients may use an acute or preventative treatment approach or a combination of the two. With symptoms and severity of migraines varying from patient to patient, it is often challenging to optimize treatment for patients, with many treatment plans being a process of trial and error. During this next section, we will discuss some acute treatment options. For many patients first being diagnosed with migraines, over-the-counter pain relievers such as anti-inflammatories and Tylenol are usually a first-line option choice. There are many different combinations of medications over the counter that are branded for migraine and headache, but many of them include ingredients such as Tylenol or ibuprofen. So, for example, this Advil migraine, it's really just ibuprofen, and it's just branded as a migraine medication. Many of the combination projects that we'll see regularly on the shelves, such as Excedrin Migraine, Excedrin Extra Strength, and Goodies, have a combination of a pain reliever, such as aspirin and Tylenol, and caffeine as well. Frequent use of these over-the-counter options isn't recommended because they do have some side effects, such as gastrointestinal issues and some cardiovascular effects. But caution. When choosing which over-the-counter product to use, be mindful if you try and combine different products from over the counter. Many OTC medications have similar ingredients or have more than one ingredient in the medication. Always look at the medication label to make sure you aren't duplicating medication you may already be taking. So here is an example. The Excedrin Extra Strength that is on this left side, the active ingredients include acetaminophen, aspirin, and caffeine. And then the Excedrin Migraine in the middle, the active ingredients are acetaminophen, aspirin, and caffeine. And then this BC powder contains aspirin and caffeine. So now, as an example, so say you're a patient and you've had a migraine for the past 2 days, and you currently take Crestor 20 once a day for your cholesterol, metformin 1,000 milligram twice a day for your diabetes, and Tylenol 500 milligrams once a day for your arthritis. And then you go to the pharmacy to pick something out over the counter for a migraine. And these are some of the options. Which over-the-counter medication would be okay for you to take with your other medications? So the key to this example is a medication that you already take at home. The Tylenol, you are already currently taking Tylenol 500 milligrams for your arthritis. And as we previously looked at, for the two Excedrin brands on both sides, both of those medications also contain Tylenol, which you're already taking. Instead of taking more Tylenol on top of Tylenol that you take every day, the Advil migraine that's in the middle, which is just ibuprofen, is a better choice. Ibuprofen is a different type of pain reliever than Tylenol, so this way you're not duplicating therapy. As discussed previously, anti-inflammatories are generally first line for patients just being diagnosed with migraines. This may include our ibuprofen and also naproxen, but can also include our prescription anti-inflammatories such as Celebrex and diclofenac and others. Next, we have our triptan medications, which are a mainstay of acute treatment for migraines. They work on blood vessels in the vein, or I'm sorry, blood vessels in the brain and on sensory nerves to help reduce inflammation. This helps to give relief from a migraine. There are many different types of triptans available, and they come in many different formulations, such as oral tablets, orally disintegrating tablets, nasal sprays, and injectables. This is very helpful for our patients that may experience extreme nausea during a migraine attack, or if a patient has issues swallowing pills. These medications do have some cardiovascular side effects, so they may not be appropriate for all patients. Most triptans, specifically the triptans that come in a tablet form, um, will, when they are being dosed, you normally take one tablet at the sign of a migraine attack. And then if you still have symptoms lasting for 2 hours, you can have another dose after 2 hours if needed. Rinval is a newer medication that is hypothesized to decrease the stimulations of the trigeminal system and treat migraine pain without affecting blood vessels. So it would be a good option for patients that have a cardiovascular disease or hypertension. One of the main side effects with this medication is drowsiness. So patients that are taking Rinval cannot operate heavy machinery for at least 8 hours after they take this medication. Combination analgesics such as Furoset, which contains butalbital, Tylenol, and caffeine, can also be utilized for acute treatment. And then this last group down at the bottom, antiemetics, those are medications that help with nausea and vomiting. So these medications listed don't necessarily treat the migraine itself, but it helps with symptoms associated with the migraine, such as nausea and vomiting that may accompany that migraine attack. Now, I'm sure somebody or everybody has seen at least one or both of these commercials, but Nurtec and Ubrelvy are both recently approved for the use in acute treatments of migraines. They're both classified as calcitonin gene-related peptide receptor antagonists, which for short, CGRPs. CGRPs are peptides that activate in some pain pathways, so blocking that receptor helps relieve patients from migraine pain. Both Nurtec and Ubrelvy are associated with gastrointestinal side effects. And normally with Nurtec for acute treatment, it's just one tablet at the sign of a migraine. You wouldn't repeat a dose. And then with Ubrelvy, it has a similar dosing to triptans in that you would take one tablet, and then if you're still having symptoms that persist, you can take another dose in 2 hours. But these medications are a great option for patients that are unable to tolerate triptans, have suboptimal response to, or have contraindications to triptan use. Medication overuse headaches or rebound headaches happen when an acute migraine medications are used frequently. They can cause the pain to return faster and be more debilitating than the original or normal headache. These are more common with acute over-the-counter medications such as ibuprofen and Tylenol. For these over-the-counter pain relievers, they should be have a limited use to 2 headache days per week. Rebound headaches can also happen with triptan medications. So to combat this, triptans such as sumatriptan should only be used for a max of 10 headache days per month. Next, we will move on to our preventative treatment options. Like we kind of previously went over before, these are medications that patients will take regularly to help prevent a migraine from happening. There are some over-the-counter supplements that have been thought to help prevent migraine attacks. Some of the common ones I found online were vitamin B2, so riboflavin, magnesium, which has been, some studies have shown that patients that suffer from migraines have decreased levels of magnesium. So supplementing that has been shown to kind of help prevent a migraine. And then some herbals such as peppermint and CoQ10 as well. These first 4 drug classes, the beta blockers, anti-epileptics, calcium channel blockers, and antidepressants, these drug classes aren't specifically designed to for migraine use and have limited to moderate efficacy with preventative treatment, but they are still regularly prescribed to help prevent a migraine attack. So some of these medications in these drug classes may be familiar to some of you. So the beta blockers, those are commonly used to help lower blood pressure and heart rate. The anti-epileptics are used to help prevent seizures. The calcium channel blockers are used to lower blood pressure, and antidepressants are used to help treat depression. All of these medications are oral, and they should be taken daily to get that preventative treatment effect. And then the last one, the botulism toxin or Botox, that is an injection that can be used for preventative treatment, and it helps block neurotransmitter signals that carry pain signals to the brain. Injections are generally administered every 12 weeks, and those require an office visit for that injection. Next, we have our calcitonin gene-related peptide receptor antagonists, or CGRPs. These are the same drug class that we previously discussed with acute treatment, but there are some medications in that drug class that are used for prevention. So these medications come in multiple different formulations, as you can see from this graph. Some are oral, intramuscular, or intravenous. And some of them do have different dosings for them. So like the Qulipta right here, that's going to be once daily. Most of the intramusculars are just once a month. And then the intravenous, that one's going to be every 3 months. But many of these having different modes of administration, so like only using it once a month, every 3 months, that definitely helps with medication adherence for patients suffering from migraines. And I know one of these medications may look familiar that we have already kind of talked about. So, which is true. So, Nurtec was approved in 2021 by the FDA to be used as preventative treatment as well for migraines. So, it can be used for acute and for preventative therapy. With prevention, it is only dosed every other day. So, you wouldn't take a tablet of Nurtec every single day. But in this graph, all of these medications are brand name, which does mean they are quite expensive at the moment. Many of them do have copay cards to help with affordability. So I know specifically Nurtec and Amovig, those both have copay cards from the manufacturer. So that does help with affordability for some of our patients. And then for patients who are pregnant or thinking of become pregnant, there are treatment options for acute and preventative therapies for migraines. Some non-medication options that can be utilized to make sure patient or making sure the patients are staying adequately hydrated throughout the day. Many women lower their caffeine use during pregnancy, but a low level of caffeine is considered safe and can help prevent a migraine with a max daily dose of 200 milligrams of caffeine per day. So I believe that's about 2 cups of coffee or a cup and a half. And then, as we stated before, magnesium is great for prevention and it is safe to take during pregnancy. And then for over-the-counter treatment options, Tylenol is safe to take during all trimesters of pregnancy. So that is an option. And then NSAIDs such as ibuprofen and naproxen can be used during pregnancy, but should be used in moderation and should be avoided during the 3rd trimester. Certain triptans, such as sumatriptan, have been found to be safe and effective for treatment with patients during pregnancy. But CGRPs have not yet been studied in pregnancy and are not recommended for use at this time. They're still relatively new and just they haven't had those studies done yet. So in closing, there are a lot of different options for patients suffering from migraines, and it's important to remember that migraine therapy is extremely patient specific. It is a process that takes some trial and error to find the right combination of medications for each individual patient. And like previously said, some things may not work for each patient. So it's important to make sure we're focusing on the individual patient when trying to treat migraines. Any questions?
Hey, thank you so much, Dr. Johnson. I was going to ask, I was actually typing it. Does dieting also have an effect? For me, I think for me, it's the weather. Whenever the weather changes, that's when I experience my migraine attacks, like the beginning of this year. And then recently, I changed my dieting around, and I observed that I've also had a lot of reduced migraine episodes. So I've stopped like eating all kinds of meat, red meat, chicken, and all that, and I'm doing more of a pescatarian diet. So I don't know if there's any studies that shows anything like that.
That's a great question. Weather is definitely something that can affect migraines that I saw. And then changing diet is a very common way for patients to stop having that trigger. So I think that's great that you've identified what triggers you have specifically. As for studies with different triggers out. There are some studies out there that show that triggers are definitely specific for each patient. And
All right, sounds good. Sounds good.
Mhm.
Yes, good afternoon. I have a question.
Sure.
I and I used to suffer from them many, many years ago, and I didn't. And I figured it was stress induced. But in the spirit of them being stress induced, I do want to ask a question. Are there particular centers of the brain that are tied specifically to migraine attacks, such as you have the autovisual, that's a certain part of the brain. I just wonder, is there a connection between those two, which kind of help a person avoid certain stimuli?
Another great question. So there are different areas of the brain. Like I kind of went over, whenever a patient has a migraine attack, visual stimuli is definitely can affect a migraine. So those areas of the brain do definitely have a part to play with a migraine attack. So those areas that I'm losing my words right now. I'm so sorry.
You're fine.
So visual areas in the brain, and then like the areas that are sensitive to sound. Those are areas that migraines will work in. Yes, sir.
Okay.
If you don't have some of the symptoms, for instance, the auras or the nausea or what have you, even though, like for instance, I've got super bad headaches that I'm just now starting to be treated for, are they not necessarily migraines because they don't have, the nausea and some, the light sense, although I do have light sensitivity, but I mean, must it be those things in order for it to be categorized as a migraine?
Correct, correct. And that is one of the things that differentiate a migraine from a headache. So a headache may not necessarily have all the factors like the nausea, vomiting, light sensitivity, and the multiple days of having that pain. So that definitely differentiates a migraine compared to a headache, because a migraine will have all of those symptoms generally, but a headache will not. It may have one or two symptoms instead of all of the four.
Okay, thank you.
Yeah.
One last question for me. Is there any tie particularly to migraines consistently of attack and frequency and intensity of it to any of sort of neurological disorders such as potentially dementia or anything? Are there a greater risk of that down the line if you have those consistently?
Um, I would have to look into that more. I would assume that there may be a tie, but I cannot say for certain. I can definitely look into that and get back to you if you'd like.
Just curious because it's okay. Thank you.
Can you speak to vestibular migraines?
Um, oh, um, I cannot at this time, but if you would like, I can get back with you a little later. You said vestibular migraines?
Yes, that's what I've been diagnosed with.
Yes.
I
There are
also have
Oh, go ahead. I'm sorry.
I also have chronic vestibular migraines, and
Mhm.
I'd love to understand how they're different from other migraines.
Yes, there are multiple different classes of migraines out there as well. And if you wanted to put your names in the chat, I could definitely get back to both of you with some information on vestibular migraines. Absolutely.
Would you happen to know if a headache associated with occipital neuralgia is considered a migraine?
Can you repeat that one more time?
I just said, again, this is all brand new to me. I mean, very brand new. But do you know of a headache associated with occipital neuralgia would be considered a migraine? I mean, it's I follow up with them soon, so I can ask these questions. I just didn't know if you knew.
Yeah. So it's similar, but it's not exactly the same. I believe there is a difference between both of those.
Okay, thank you.
You're welcome.
Hello, this is Patrick from Baptist Best Health. Does anyone have any more questions before we go? I just want to be mindful of everyone's time. So any other questions?
No, thank you.
Okay. All right. Well, I want to say thank you to Dr. Johnson for giving us your time and your knowledge on such an important topic. And also thank you all. Thanks to all of our participants. And as I mentioned earlier at the very beginning, this presentation will be recorded or is recorded and will be shared with everyone over email and posted on the Best Health SharePoint site. So definitely give us a few days to get that processed. So thanks again, everyone. And I hope you all have a great day. Okay. Thank you all.
Thank you.